Thanks, James, very much. I want to thank the organizers for inviting MSF to speak at this symposium. And it's an honor to participate alongside a researcher, policymaker, and educator like Peter Piot. Your name is well known in MSF circles, and we look forward to ongoing collaboration in the future. Médecins Sans Frontières, or Doctors Without Borders, is an international medical humanitarian organization that many of you will know of. We were the first outside organization to investigate mysterious deaths in Guinea in March 2014, confirming Ebola several days later. By March 31st, given the geographic spread of cases in a region completely unprepared, with the sick, their caregivers, even the dead, moving between villages and countries on a scale never seen before, we publicly declared the outbreak unprecedented. After responding to a dozen outbreaks of Ebola, this was clearly different. The next day, however, the World Health Organization and local governments rejected our concerns. By late June, with outbreaks in 60 sites across 3 countries and MSF stretched beyond its capacity, we again raised the alarm, declaring the epidemic out of control and requesting international support. Not only did support fail to arrive, but MSF was accused of alarmism. It was not until late July when an infected diplomat flew to Nigeria and a sick American was repatriated that the world woke up, realized the virus was crossing oceans and distant borders, and took action to stop it from coming to their countries. Ebola had become an international security threat and no longer a humanitarian crisis affecting a handful of poor countries in West Africa. Initial international response, however, was not to address the epidemic at its source, but to close borders to trade and travel in vain attempts to keep Ebola out of our own backyards. Support to West Africa finally did arrive, albeit too late. Now, with more than 28,000 infected and 40% dead, the epidemic seems to be reaching a close. MSF treated 1/3 of all the patients, set up 15 Ebola management centers, and deployed thousands of staff to carry out the hands-on work that was needed from the beginning. And in doing so, 28 of our own staff became infected. 14 died. Statistics, however, mask the field-level reality. In Monrovia, the capital of Liberia, at the peak of the epidemic, the MSF teams were overwhelmed by patient volumes, providing food, shelter, and comfort to those they admitted, and watching as others literally died in the streets when the centers were full. At its worst, they would open their doors to new patients for only 30 minutes a day, admitting a select few of those pleading for a bed inside, forcing the teams to make impossible choices on who might live and who would likely die. My own experience with patient volumes exceeding capacity was also painful. I worked as a field doctor in an Ebola management center in eastern Sierra Leone. Our patients were sent from literally across the entire country, as no other Ebola center beds were available. These rides took up to 8 hours along roads in extremely bad condition. The backs of the ambulances were hot in the heat, made worse by the vomit and diarrhea from the sick. Windows were closed while driving, as fearful villagers often threw debris at the ambulance, hoping it would not stop in their town. The ambulances were packed, occasionally 6 or 7 people in the back. The worst part were the deaths inside the ambulance en route, leaving the remainder of the patients to sit cramped beside the body, which was often a loved one. In the words of senior MSF leaders, the Ebola outbreak has often been described as a perfect storm, a cross-border epidemic in countries with weak public health systems that had never seen Ebola before. Yet this is too convenient an explanation. For the Ebola outbreak to spiral this far out of control required many institutions to fail, and they did, with tragic and avoidable consequences. For months, ill-equipped national health authorities and volunteers from a few private aid organizations bore the brunt of care in this epidemic. There is something profoundly wrong with that. It is an important privilege to be here today to talk about lessons to be learned from MSF's perspective. I will focus on the field medical operations, strategic choices, and leadership, as well as broader system issues of research and development and global health governance. In keeping with our purpose as a humanitarian organization, my comments reflect response in support of populations most vulnerable. Despite having treated over 5,000 confirmed patients, MSF did not learn enough about Ebola virus disease or how specific treatments impacted patient outcomes. In our defense, our management centers were completely overwhelmed with patient volumes. For obvious reasons, biosafety was paramount, a fact that left our treatments quite basic. I had to record patient data after rounds by verbally yelling it to a record keeper over a fence while standing in personal protective equipment. As patient volumes dropped in late 2014, we had more time to focus on clinical details, such as what data to collect in monitoring response to treatment, what lab tests might be of use, and implementing better palliative care protocols. We had the opportunity to reflect on these questions, such as could we develop portable or mobile Ebola management centers, given the unpredictability of outbreak locations, and critically, why did our patients die suddenly and unexpectedly? At the same time as numbers declined, we also lost the opportunity to study some of these issues definitively. While much experience was gained in patient management throughout this epidemic, there remain many key knowledge gaps that must be tackled in future outbreaks. Operational research must be prioritized for the next outbreak, with study protocols and ethics approval addressed in advance, ready to roll out at the outset. And thankfully, with people like Rob Fowler, this is happening. We must do a better job, an earlier job, of addressing the non-Ebola needs of vulnerable populations, such as pregnant women or the under 5-year-olds. Attention was understandably focused on the Ebola outbreak, but this had the effect of marginalizing more or less every other health issue. As hospitals and clinics were closed across West Africa or bypassed by the population for fear of contracting Ebola, regular illness went unaddressed. I imagine the mortality from things like malaria, pregnancy complications, or trauma was far higher than that from Ebola itself. The UN Population Fund estimated 120,000 pregnant women in West Africa would face complications over the past 12 months, potentially leading to death. Vaccinations programs stopped, the consequences of which will be felt for some time to come. As MSF found some breathing space in its overall response, we began to roll out programs like citywide blanket malaria treatments, treating 1.2 million people over 3 days in Freetown in December 2014. We set up a maternity hospital in Freetown as well. These projects, however, were still patchwork. Future Ebola responses will need to find effective approaches for maintaining access to non-Ebola care during an outbreak, including better infection control standards in clinic and hospital triage areas. As an organization of medical people, MSF tends to gravitate towards curative care. However, by necessity in this epidemic, we learned a lot in terms of community outreach, behavioral change, and health-seeking practices, areas we are not historically strong in. The importance of the community-level efforts, going door to door to explain to each family how the virus is transmitted, what the symptoms are, and what to do if someone falls sick and how to care for them safely, cannot be overestimated. Taking the time to listen and respond on a personal level has been proven to work. The ultimate key to success lies in gaining the trust and confidence of local people. Future epidemics must better prioritize community engagement, asking communities how they can best protect themselves, and working with their leaders to implement behavior change. For any organization, having a clear set of policies and procedures for addressing the health needs of its staff is critical. For MSF, this was patchy in the initial stages of the Ebola outbreak. It was not clear whether our international staff could be evacuated to their home country should they become infected. Worse, There were no higher level of care facilities for our West African staff at all, aside from the overwhelmed Ebola management centers they were already working in. It was not until November 2014 that more or less all of our international staff had guarantees of being let back into their home country if infected, and a UK-run high-standard Ebola management center opened in Freetown, Sierra Leone, dedicated to healthcare workers. It also became painfully clear that risks to our national staff were significant at home, caring for colleagues and family, as most of our staff who contracted Ebola picked it up outside the Ebola centers. While our biosafety protocols were rigid inside the management centers, similar attention must be placed on our staff being able to protect themselves at home. Beyond field operational issues, strategic decisions made during the outbreak should also be scrutinized. At the outset of the epidemic, MSF was forced to make several tough strategic choices due to the overwhelming nature of cases spread over 3 countries and the limitations of our human resources. Our response varied from location to location and over time, but for the most part, isolation and care for patients was prioritized over outreach and community work. There was an impossible tension between curbing the spread of the disease and providing the best clinical care to each patient. This became particularly acute in August 2014 in Liberia when case numbers spiked. Our facilities were over capacity and we were only able to provide the most basic palliative care to patients, prioritizing the admission of people who were highly infectious in order to reduce the spread of Ebola in the community. Our chosen focus was patient care, and given the lack of other actors present, it meant outreach and community engagement was marginalized. In retrospect, an understanding of the communities we work in is paramount to the success of all our activities. Therefore, community mobilization and health promotion must be recognized as interventions in themselves rather than only as support to other interventions. Equally, surveillance and contact tracing must be recognized operational priorities and appropriate resources invested to develop consistent guidelines, tools, and expertise. In an epidemic of this magnitude, with national health systems unable to respond adequately, organizations capable of carrying out all necessary pillars of response are needed. No single organization can carry that burden. Faced with an epidemic that clearly outstripped MSF's human resources, we called for support publicly, asking other actors to step out of their comfort zone and respond for the first time to an Ebola outbreak. To facilitate this, MSF offered training in Europe, which was appreciated by participating organizations, some of whom then trained others, leading to a multiplier effect. However, the training was not adequately replicated in the field, and it neglected important topics not directly related to Ebola management centers, notably outreach. After 18 months of international efforts, there is a healthy depth of experience built up in responding to large-scale outbreaks of hemorrhagic fevers. However, if other pandemics arise, outstripping expertise on offer, training of staff from other organizations should be done faster and more comprehensively. Despite massive efforts in addressing the epidemic in the 3 highly affected West African countries, concerted attention was still paid to the neighboring countries. When Ebola entered Nigeria, Senegal, Mali, various organizations, MSF included, supported their governments in containing the disease. The biggest concern was Nigeria. In late July, Ebola arrived in Lagos via an air passenger from Liberia. Despite the virus entering a city of 20 million people, only 20 people were affected, with 8 deaths. The Nigerian government's fast response, deploying significant human and financial resources and implementing rigorous infection control measures, was critical in avoiding a widespread epidemic. The experience in all 3 peripheral countries highlights the importance of preparedness, surveillance, and rapid response at the beginning of an outbreak. It is impossible to address lessons learned from the Ebola epidemic and not talk about the failure of leadership. A rapid and effective epidemic response will not happen without leadership. The WHO is and should remain the leader in global health. But today, it lacks the capacity and expertise to respond to epidemics. During the recent World Health Assembly of UN member states and stakeholders comprising the WHO, it agreed on a set of reforms to improve the organization's global health security capacities. Some, such as long-standing WHO collaborator and global health law expert Lawrence Gostin, feel these reforms will not address the deep structural problems that continue to plague the WHO. The main issue is the incoherence between the WHO's global health leadership mandate and the inadequate funding and control it receives to carry this out. Too often, decisions made by the WHO are influenced by political and economic concerns, fostering a culture of risk aversion. We should question how the WHO sets its priorities when the top donors are the US government and the Gates Foundation. WHO's in-country managers should be chosen not on a political basis. They should be recruited for their expertise and held accountable for the effective implementation of their responsibilities. There needs to be a swift paradigm shift in the way the WHO operates, which would put the health of people at risk as the #1 priority. Though reforms are on the table, it seems unlikely that radical reform will happen overnight. Realistically, few member states have any interest in empowering an outside international body to respond to epidemics in their territories. Nevertheless, while the WHO's ability to prevent infectious disease outbreaks is unlikely to be improved, its outbreak response capacity will apparently be better than before. Moving away from the field level, the Ebola epidemic is another example of the weakness of the current global research and development system to develop much-needed medicines and diagnostics for neglected diseases. Millions suffer from diseases for which effective drugs or vaccines are priced out of reach or do not exist, as they don't represent a lucrative market for the pharmaceutical industry. Ebola was no different. Historically, it affected only a limited number of economically disadvantaged patients in short-lived and remote outbreaks in Africa. Biomedical innovation will always be a potential game changer, but it will continue to fall short if it is driven by market forces, fear of bioterrorism, and defense agendas, rather than the needs of patients. The R&D agenda must be reoriented towards the greater public good to compensate market mechanisms when they fail to deliver. Outcomes of R&D should be made available, affordable, and accessible to those in need. This will require a fundamental change in the R&D system. But there are promising examples of alternative models to fund and incentivize it. Such an R&D system would also avoid losing critical months during a pandemic, as was the case in Ebola. It would conduct safety studies and address ethical issues during inter-epidemic phases to allow fast-track use of experimental drugs and vaccines during an outbreak, launching clinical trials as the epidemic peaks. Too often we scramble to act only as the epidemic peters out. The WHO decision in August 2014 to confirm the use of Ebola products not yet tested on humans as ethical and even encouraged was highly beneficial. Public and private research sectors fast-forwarded the R&D process to start clinical trials from what usually takes years to mere months. This was incredible. Perhaps the global health community could agree on a priority list of emerging infectious diseases to tackle for future outbreaks, guided by the needs of all patients. Finally, the global health framework for epidemic response is guided by the 2005 International Health Regulations, or IHR, which is overseen by the WHO. The IHR is officially meant to, quote, prevent, protect against, control, and provide a public health response to the international spread of disease that constitutes public health risk, while avoiding unnecessary interference with international traffic and trade, end quote. Given the poor performance in the Ebola outbreak, it would seem the IHR is unfit to guide or resource what is needed for epidemic responses and in need of further revision. For example, the IHR stresses public health surveillance, but this alone is meaningless without a capacity to deliver direct care to affected populations. Next, the IHR relies on state sovereignty and inadequately addresses international response mechanisms or population concerns when countries are ill-equipped or unwilling to act. Lastly, as a matter of reciprocity, countries willing to declare and respond to an epidemic need supportive incentives in the system, and not only the prospect of economic, political, and financial punishment, like closure of borders, interruption of trade, and decline in funding. This breeds fear, which proved well-founded when the global health community initially responded to the Ebola epidemic with containment measures, worsening the epidemic and delivering a massive economic blow to already fragile post-war nations. It is impossible to disconnect the discussion on pandemic preparedness and response from the development of functioning healthcare systems, which must include preparedness and response to local epidemics. The building of an effective emergency response is an integral part of health systems strengthening and an indicator of their quality. This also requires resources and support from the international community. Restoring West African healthcare systems to pre-Ebola levels without addressing the underlying flaws and weaknesses is not enough. Improving access to and quality of healthcare services will be necessary to allow early detection of any future outbreaks of infectious diseases, as well as more effective response. Sadly, the example of Haiti following the 2010 earthquake does not bode well for Guinea, Sierra Leone, or Liberia. In the end, healthcare systems have to be constructed to serve their people, and the needs of affected populations have to be the cornerstone of any health system. And yet, the high number of vaccine-preventable disease outbreaks in fragile countries around the world not only exposes the weaknesses of many national health systems, but also the shortcomings of the current global health regime. In dealing with pandemics, international organizations have responded exactly as they were designed, first and foremost to maintain global health security and protect nation-states from transborder health threats. As a consequence of this defensive logic, the response to Ebola in 2014 was unduly delayed, causing a horrific number of deaths in the region. By contrast, when the first Ebola cases were seen in richer nations, rapid decisions were taken at the highest international level. What some scholars have called the securitization of health has put domestic and international interests ahead of the health of populations. But health policies cannot be limited to security considerations. MSF sees health security as a commitment to secure or improve the health of all, including the sickest in the most vulnerable societies, without discrimination. This approach has intrinsic value. It is also a way to improve disease control, since the success of any meaningful public health strategy relies on putting the interests of the patients first. In the end, communities infected with a highly contagious virus are not biohazards. They are patients with families. Ultimately, health is a public good and must remain a shared public responsibility. I have tried to provide some thoughts on lessons learned for future pandemic response based on MSF's experience in the Ebola outbreak. While I am confident civil society organizations like MSF have the will and ability to adapt and evolve an epidemic response, I am less optimistic for meaningful evolution globally. The overall global health and humanitarian systems are too fragmented, too dependent on political will, and in need of a WHO that is funded, structured, and staffed to provide the requisite leadership. Basically, the international epidemic response system is not working. And lessons learned on large-scale epidemic response have a tenuous track record. Just look at the mass cholera outbreak in Haiti 5 years ago. To make matters worse, numerous crises around the globe are competing for the same attention and resources. Refugee numbers have reached their highest levels since World War II, with spread across Europe. Conflict rages in Syria, Yemen, Central African Republic, or South Sudan. The Ebola response was a political failure, not a failure of means. The reality is that should another Ebola outbreak hit today, where wealthy country interests are not threatened, our response may not be a lot better. This is not about preparedness and crisis response modeling or massive investments in parallel systems. It's about putting the needs of patients, communities, and health workers first in country. And yet over and over again, where the political fails, civil society is left to do what it can for those most vulnerable, especially in epidemic response or situations of conflict. The result is an over-reliance on medical humanitarian organizations substituting for the absence of public health services, privatizing global emergency response in challenging contexts. This must not be allowed to continue. I have no easy solution to the problem of interested political will. But as the ideal is to have a global health system able to address the needs of the individual, perhaps the solution also comes down to the actions of individuals, pushing the system, any health system, to be more patient-centered. As a physician, I do my best to take care of the patients arriving in my emergency department. Too often, there is nothing I can offer medically. Yet taking the time to listen to their emergency, providing empathy, and perhaps restoring some dignity in their time of crisis is something I can offer everyone. But it takes time, and so I balance my requisite efficiency in a busy emergency department with the needs of the individual. As an educator, I attempt to instill similar values in my students. As a humanitarian, I believe in an ethic of refusal, a refusal to accept a status quo where people suffering under repressive regimes or in forgotten corners of the world can be denied assistance, whether medicine, food, or shelter. If enough global health practitioners, policymakers, and pioneers of tomorrow could get their hands dirty, working alongside the most vulnerable, and combine that with a sense of empathy and an ethic of refusal, who knows how the global health politics and paradigms of today might evolve? With leaders like Dr. Piot directing one of the foremost global health schools in the world, I see significant potential to shape the minds and thinking of global health leaders of tomorrow. But for now, I leave the issue of global health politics to our next speaker. I will finish with a small story from the day I was leaving Sierra Leone last December. As I was crossing the country, heading back to Freetown in our Toyota Land Cruiser, a song came on the radio. It was Kenny Rogers, The Gambler, sung by a Sierra Leonean performer. Just try and imagine it. You gotta know when to hold 'em. Not 2 lines into the song, our driver, a local, began to sing quietly along. And he smiled when I joined him at the chorus. And we both laughed when the guy in the back chimed in. There we were, 3 men who had only met that day, singing an American folk song together in a car, badly, but laughing the entire time. So I don't know if that's possible. Maybe anything is. Thank you.